Hi everyone, thanks for having me along, and thanks for Dave and SDF for inviting me. Now let me just get myself up to speed with the clicker. Oh no, what's that? Okay, yeah, that's me I think. Right. Okay, as Dave said, I'm going to be talking a bit about perhaps older people who have significant problems related to drugs. And a lot of this will be going to on the back of the report we put together with Dave and various other folks, some of whom you're here today, looking at the health and social care needs of older drug users in Scotland. And this sort of slide, I've presented this a few times, so I'm very sorry for those of you who've heard me before. I'll try and mix it up a bit, and I promise this will be the last time I ever use this slide. It will also be the last time I present with my broken glasses, so it's a momentous occasion for me. So we're talking about that cohort of folk that Leslie's been referring to, brought up in the 70s, 80s and 90s, who are now representing the majority of people who are presenting to drug services. Okay, so this isn't a minority, this is the majority of people who have problems with drugs in Scotland are now over the age of 35. Now I know it's a little bit shocking for us to think of people over the age of 35 as old. I think one of the reasons that we took that age cutoff when we were looking at the evidence in terms of the health and social care needs was partly so we had more information to make projections on, and colleagues in ISD would be able to use the data to make these kind of projections about what is going to be happening in the future. But I think also it represents something that Leslie touched on, that this is a group of people who we're talking about who have multiple health issues with accelerated physiological aging. So we're seeing the kind of health conditions in folk in their 40s that we would more likely see in folks in their 50s in the general population and in their 60s. I don't know if any of you saw the paper that was in, probably you didn't because no one reads the British Journal of General Practice, but there was a paper from Glasgow here, from the homeless practice in Glasgow, profiling their patient population, registered patient population. Their average age was 42, but the average health profile compared to the general population was that of a population in their mid-80s. That's in terms of the number of comorbidities and the severity of those morbidities. Now that is perhaps at one extreme, but I'm going to be suggesting that actually when we're talking about disadvantaged groups, whether it's people that are homeless in the criminal justice system, in the sex industry, significant drug problems, it's massive crossover, and often we're talking about the same people. So as you can see, the aging cohort is top line, the aging group, which is plateauing, and in fact they've even projected it's going to be dropping off a bit in the mid to late 2020s. What you'll also see there, when you look into that older cohort over the age of 35, the cohort itself is aging. So increasingly the proportion of people in their 50s, in their 60s, and if one or two of them make it into their 70s, will be increasing. So the levels of social and healthcare needs will be rising over time. Okay, one of the things that we did as part of the work around the report was to get some peer researchers to interview folk with drug problems who are accessing different services around the country. It was third sector services, and they interviewed 123 folk and then did some more in-depth interviewing and thematic analysis with a quarter of those. And these were the issues that people were identifying that they were struggling with. So you can see homelessness, 91% of people in that cohort had actually identified homelessness as an issue at some point. Criminal justice issues. Isolation, we've heard a little bit about that. Well, certainly loneliness, people living alone, almost 80%. And then this revolving door through treatment. 37% had been in treatment 5 or more times. We haven't identified exactly what that means, but that means specialist treatment with drug and alcohol support services. One of the things that was particularly concerning was the average length in treatment. The last episode of treatment was 12 weeks. And we know that in order to benefit from opiate substitute treatment, we need at least 3 months of treatment before people get over the risk periods and start actually reaping some of the benefits. So short treatment episodes, multiple treatment episodes, and incredibly high levels of self-reported mental ill health. Over 90% of people identified themselves as suffering with depression, similar levels with anxiety, and chronic pain as well. Over 50% of people were in pain. So this is some of the other qualitative things that came out. I've jotted down a few of these. People were concerned that they often felt forgotten about in services, that they were left. They felt there was a lack of support around opiate substitute prescribing, which actually hampered their engagement and hampered their progress through the service. And they valued the time to talk. They valued workers that actually spent time talking. And they also, at the end there, one thing that we picked up was they felt they had something to offer as well. There was some positives. People felt that their lived experience could be used to the benefit of others. And certainly that's something in our practice that we're trying to wrestle with how we can engage with people with lived experience who actually often want to give something back. So these are the key themes that were coming through. Welfare reform is a big issue. All of us here, I'm sure. I don't know if many of you struggling with universal credit at the moment and the impact on your clients or impact on yourselves. We haven't been hit in terms of our homeless patients in Edinburgh, but we're going to be hit later in the year, and we're bracing ourselves for a storm, which I'm sure we'll hear more about in a minute this afternoon around welfare reform. One of the things that came out was still the punitive approach by some services to service users who don't quite fit the bill, don't quite fit the rules, regulations. A couple of quotes around some of the mental health and isolation issues. This is a fairly typical type quote. And then stigma came out as a significant issue for service, the individuals themselves, in terms of hampering them making use of services and feeling that they weren't taken seriously around pain issues and other health concerns. And then we did some work with the ISD, and this was sort of data linkage, looking at primary care prescribing, hospital data systems, and very much as Leslie was referring to, seeing hospital admissions, high rates of admissions, particularly for these conditions listed up here, in comparison with the general public. So again, building up a picture consistent with the peer research of a group of patients, a group of people with multiple health conditions, which does cause them to be encountering and utilizing services, but often in an unplanned and possibly unproductive way in the long run. So this is, you'll see the red line at the bottom. This just shows hospital admissions in those over 35, and what you can see is they are now the main admissions related to drug use compared to those under 35. And that's been rising over the years. We looked at some of the conditions I just highlighted just now, and I'll just flash up a couple of slides looking at hospital admissions around two specific areas. One is chronic respiratory problems, chronic obstructive pulmonary disease, asthma, and the other is depression. Now, going from the top down, it's the younger folk at the top, older folk at the bottom. Just to tip things on their head from a gender colour point of view, female data is in blue and male in red and pink. what you can see basically is that the lighter shades underneath the darker blocks is in comparison with the general population in terms of, I think it's per 10,000 of population in terms of hospital admissions. And you can see that as you go down the blocks, you get, I think it's actually like a 6 or 7-fold increase in hospital admission rates for chronic respiratory conditions in the older age groups of folk with drug problems. And then if you look at mental health in terms of depression, you see an even more dramatic picture. You get more than a 10-fold increase in the older age groups, particularly with the women, in terms of admissions to hospital for depression. Again, this is very much consistent with the data, other ISD data, and the data, the research that the peer researchers generated through interviews. So we're talking about a group with very significant physical and mental health difficulties. And this is just reflected, again, like mirroring the slide from Leslie, in terms of the actual number of bed days, or number of days in hospital that actually folk over the age of 35 with drug problems are occupying just now, which will increase over time. So the grey colouring is those over older, over 35. The red colouring is those under 35. So you can see over the coming years, we're going to be having a lot of more people in hospitals as a result of drug-related problems. And that translates, this is it here, and this is just some of those projections. The majority of those admissions are going to be emergency unplanned admissions. And what we know from other work with here from Glasgow, Stuart Mercer and his team, is that the majority of unplanned admissions, which are preventable, are amongst younger adults from deprived backgrounds. So these are potentially, many of these will be potentially preventable admissions. And these are the costs involved. So we've got the blue underneath in terms of the costs, increasing hospital stays. Then we've got the red sliver above, the costs associated with drug treatment services. And then we've got the overall prescribing costs in green. And what you can see quite dramatically is the costs are in the unplanned, potentially preventable hospital admissions. So how much sense does it make cutting services, cutting resources to services that can potentially prevent admissions, given that that is the cost, the consequence? So we are going to pay financially and sadly in human terms one way or the other. So it is about how we use the resource that we have as a country in a way that actually makes a difference. And then the ultimate cost, which we've already seen, is in the rise in drug-related deaths. And the vast majority of that rise is accounted for by the increase in older folk dying from drug-related problems. The deaths, mostly overdoses. Okay, so that's not picking up other deaths that might be related to liver disease, mental health. This is predominantly overdoses. So I thought we'd maybe think a little bit about who are we actually talking about. And I touched on this earlier. There's been a little bit of work around severe social disadvantage. And this is from a report, the Hard Edges report, which is actually from a Scottish group in Heriot-Watt University, Suzanne Fitzpatrick and her team. And I think they're now doing a similar project up here in Scotland. It's a data linkage problem, looking at who are those really on the margins that we're seeing in our services or not seeing in our services. And the three areas that they were looking at in terms of disadvantage were those that were homeless or a history of homelessness, known to homeless services, those who had a history of offending and actually were known to the criminal justice system, incarcerated, and those who are known to substance misuse services. And what you see is there's a big overlap. So the majority of folk are known to at least 2 of those services or service areas. And again, we've been thinking a little bit about this already this morning. This idea of severe and multiple disadvantage. What is it about this group that makes them so disadvantaged that it's actually playing out in these rising levels of death and morbidity that we're seeing? And again, this is from the Hard Edges report, and they talk about the degree of stigma and social dislocation. Okay, so when we're designing services for this group of people, we're not talking about designing services where your cardiologist sends out an appointment, the person doesn't turn up, the cardiologist discharges them, because we know that's not going to work for the majority of this severely dislocated, stigmatized group. We need to think about how we develop services which enables people to engage in a meaningful way and make use of the services. So discharging people for non-attendance makes no sense. Sure, from a service point of view it makes sense. They're off the waiting times list, they're out of the picture. But if we want to do something of that rising cost in financial and human terms, discharging people for non-attendance makes no sense. We have to think differently. Okay, some of you might have seen a couple of papers in the Lancet in November. This is from the Faculty of Homeless and Inclusion Health, based down in London, Nigel Hewitt and Al Story. They did a big meta-analysis about what works when we're talking about inclusion, populations, services to meet the most disadvantaged needs in our society. These were some of the highlights from their report about what works. Poverty. We've got a situation in the UK where in the next few years, almost 1/3 of children will be brought up in poverty. Housing. People when they had a part of their report, not only was looking at the meta-analysis of the literature, but also events involving people with lived experience. And very much housing, addressing housing needs was seen to be one of the key issues in terms of improving people's health, well-being, and long-term outcomes. Services need to address the range of people's problems. So when we're talking about excluded groups, marginalized groups, and that is people with long-term drug problems, okay, then we have to be able to address the triple morbidity of physical, mental health, and substance use. So all services, I would suggest, certainly all clinical services, working with this population group should be able to do something about the triple morbidity, because we know that people get lost between services. So if someone's in contact with a service, that service contact, the utility value of that needs to be absolutely maximized. We need to remove barriers. There was an audit in Edinburgh in 2016 of drug services, and it was like 50% of people were lost to contact with services within 3 months. How many appointments do people have to go through before they get started on opiate substitute treatment? We know that's the glue often that holds folk to the service. That enables them to start making use of the counselling, of the physical health stuff, of the support. Without that, people get cut adrift. How many appointments are we prescribing at first contact for those who are high risk? I'm sure some of us are, but that's a discussion we should be having. Involving people with lived experience to actually look at those barriers, to look at how we design services that actually are welcoming people in and enabling people to stick. And the other one of the things, of course, opioid substitute treatment is highly effective at keeping people alive. Okay, just you're probably more familiar with a lot of the evidence around OST than I am. There's a lot of evidence that older people in treatment do well. They do even better than younger people if you can get them into treatment. I pulled that out of a European monitoring report from Lucas a while ago. So some of the issues, Dave, am I okay? Or am I? Okay, good. Okay, so some of the issues that were coming through, multimorbidity at a younger age. We talked about people 15 years older at least. We know in the general population, not with those with a drug population, that multimorbidity hits 10 to 15 years earlier those from the most deprived decile of the population. Now we're talking of people who are actually even further down that road, sadly. Commonest comorbidity is mental health. I'm going to just pick up a couple of things from this list. One, I want to just talk a little bit about hepatitis C treatment. Edinburgh Access Practice, this is where I work, and a colleague Paul over here as well. We've been doing some work with the local liver centre to get folk into hepatitis C treatment. We found that none of our patients ever made it through to specialist services. If they made it through, they're out the door pretty quick. So in discussion with our MCN, we eventually got money to have a specialist nurse come to the practice 1 day a week and started getting folk into treatment a few years ago. So we have high prevalence of people with drug issues. This is of last year. I think we tested just under half of our patients for Hep C. 53% were positive, but if you looked at those with a history of drug use, it's 65%, which is certainly a lot higher than the Edinburgh prevalence figures. And 70% of those were chronically infective, so they had active infection. So we started treatment a few years ago on the old ribavirin and PEG interferon, and we kind of made some progress. We got a few folks through treatment. It was a major effort. And then we virtually were stopped treating because we were made to put our patients on a waiting list. As soon as we operate waiting lists, we know that huge swathes of the people that most need treatment will never make it because things happen. They're in prison. They lose their housing. They lose their support. They relapse. They're out of treatment. Waiting lists do not work for the patient group that I'm talking about. So we eventually managed to get rid of the waiting list and they said, okay, we can start treating people again. At the same time, we've got the new direct-acting antivirals. I don't know if any of you have experience with these. They're absolutely fantastic. 8 to 12 weeks treatment, 1 tablet a day sometimes. You can run it alongside the methadone in the chemist. 95% plus cure rates. Almost no reinfection rates, something like 2%, I think the data is. Hugely cost effective. We can seriously start thinking about epidemic eradication. So we got 53 folks through treatment successfully. We're really looking to put 50 folks through treatment every year, more if we can. And we have got a very rapid turnover because we're working with homeless people and moving in and out of our service. So that gives us quite a reach to reach quite a lot of people over a few years. Now, I would suggest that every clinical service in contact with drug users should be treating people for Hep C. For us, the key person is a nurse assistant. She runs it. We have the Hep C nurse who comes out 1 day away. The nurse assistant is the contact point. She knows everyone, gets them in, and I'm in the background. I don't actually do anything, but I'm in the background because I'm the doctor. You don't actually need a doctor for any of this stuff now. Sure, you have to do it properly, but it is so simple. One of the big things we see about Hep C treatment is it goes some way to removing that stigma, that tainted mark that people feel, that feeling of being dirty with a lifelong infection. And we've seen lives transformed. Folk go on to HNCs, set up self-help groups, speak at Parliament, all sorts of things. Can be quite a transformative intervention. And I think we should be seeing Hep C treatment as a mental health intervention as much as anything else. Chronic pain. I'll come back to the chronic pain just in terms of medication we know doesn't work very well for chronic pain. Gabapentinoids don't work very well. Okay, less than 20% of people on gabapentinoids getting any meaningful benefit. So chronic pain, just hold that thought. We need to be developing psychologically informed services. We've heard about trauma. Psychologically informed services incorporate the ideas about working with people with trauma, but extend it right across how we structure and design our services. And I'm going to say a little bit why that's absolutely core to everything we do if we're working with folk who are severely disadvantaged. Okay? We've heard about adverse childhood experiences. And the trauma-informed bit, this was a real light bulb moment for me, was when we're dealing with patients and that who are really struggling with, moving from what is wrong with you? Why is it you can't take the tablet I'm giving you? To what's happened to you? What is it that's happened to you that has brought you to the situation you're in now? And that for me has been quite a significant thing of how I can then start to relate and empathise with my patients. Should we be routinely inquiring about adverse childhood experiences? Is that something we should be inquiring about as part of our routine assessments? Because we know that it takes about 16 years for someone to disclose serious childhood adversity. And we know in the disclosure process itself, there is a huge cathartic benefit to that, regardless of whether we're specialists or actually have specialist treatments to follow it with. So ACEs, adverse childhood experiences, huge lots of evidence accumulating, a lot of stuff going on in Wales, a lot of stuff going on in Scotland now. Tenfold increase in your likelihood of having serious drug problems if you've had 4 adverse childhood experiences. By that we're talking about abuse, neglect, parental criminality, parental loss, parental mental health problems, a range of adversity. And these are not equally distributed, and their effects are not equally distributed across society. They are concentrated in areas of poverty and deprivation. Okay, so we need to in order to work with folk who are coming from those kind of backgrounds, and I'm sure many of you in the services that you're in will be thinking about this stuff, will be developing this stuff. To work with folk from that background, we have to have services that are psychologically structured, okay? Now, we've talked about the psychologically informed environments. We could talk about psychologically informed services, but the acronym would be PISS, so it's PI. Okay. So these are a few of the key features that our services, the environments we're bringing people into, need to be having, need to be core features. Okay, the valuing of relationships. There was the idea that you can be creative, have initiative, develop things with your patients, with your service users. And that, again, the moving away from the what's wrong with you to what's happened to you. I know it sounds a bit naff, but that, behaviour is a form of communication. Our patients aren't doing what they do for a laugh. They're doing things the way for a reason, and about trying to understand that. And often with the childhood trauma thing, and I don't know much about this at all, but I'm just starting to realise a little bit, perhaps, helping people to understand where they are at the moment in terms of what's happened to them can be very liberating. So not only is it the right thing to do, is it the clinically appropriate thing to do, it's also the legally appropriate thing to do. We have a legislative duty not to put barriers in people's way. We need to be addressing stigma. We need to be concentrating, at the last bit of this, on some of those folks who are most struggling. Okay, and that means even treating folk preferentially, perhaps, who have greatest need. And I'll whiz through the rest. We'll be talking a bit later about housing issues and services that can offer support and help across a range of issues that our patients struggle with in terms of housing, welfare, employability, productive activity. And why do we need to increasingly do this? Well, this is from a report, a UK, well, mostly I think an English-Welsh report actually, which shows how effective welfare change has been in redistributing wealth. And it has redistributed wealth away from poorer people and poorer areas. So it's been a very effective policy for wealth distribution, sadly in a completely retrogressive way. So that's pretty much me. The other thing I would just maybe touch on, we've got 61,500 people with drug problems in Scotland. Now, it would seem to me it's very unlikely we are ever going to be able to generate big enough specialist services to deal with 61,500 people across Scotland. So it means specialist things need to be turned on their head, perhaps. Specialist services need to be supporting the generalist services, drug and alcohol community projects, and particularly general practice, I would say, as a clinician in general practice. And we need to be gearing our services to support those frontline services and workers, because they are realistically the only services that will be able to make contact with all people that need help and support. Now, I don't want to blog on too much about general practice, but it is the only health service that has virtually 100% coverage of the population. Now, we're restructuring general practice in Scotland. General practice is going to be working on a cluster basis, we're going to be working different ways, and drug treatment services could take this opportunity to seriously look how they can integrate it with generalist community-based services, because that's the only way we are going to reach all those that need that support and treatment. And that's me.